tightrope for the blocks. Dr. Lavanya Kapati is a professor in the Department of Anaesthesiology at Sri Devaraja URS Medical College, Kolar. She is actively involved in national and state level conferences, CMEs and workshops as a faculty member. Her key areas of interest include obstetric anesthesia, clinical teaching and academic development. She will guide us through the balancing safety and efficacy in regional anesthesia. Over to you, ma'am.
Good morning, everyone. Thank you, respected chairpersons, for the kind introduction. It's an honor to be a part of ISACON Karnataka 2025. I would like to thank the organizing committee, especially Bangera sir and Shripad sir, for this opportunity. Greetings from Sri Devaraja's Medical College, Kolar. Let us now go into the topic, a critical clinical scenario which we are all facing regularly, a topic called regional anesthesia in patients on anticoagulants. Regional anesthesia is no longer an adjunct. It is one of the most important part of the modern perioperative care, keeping in view the better analgesia and going in line with the ERAS protocols. As the life expectancy has been increasing, we see that more than 20% of the population of India is going to be, that is 1 in 5, are going to be over the age of 60 by the year 2040. And a cohort study shows that among the elderly patients, 56.8% were on antithrombotic therapy. This means that we would have more and more patients on anticoagulants, and that would be the norm, not an exception. There's the evolving pharmacology, newer agents coming up, and the direct oral acting coagulants have overtaken and replaced warfarin. Low molecular weight heparin still continues to be used in the perioperative prophylaxis, and dual antiplatelet therapy is the standard. So now the clinical dilemma is, should we stop the anticoagulants before the bleeding risk, before the blocks, or to reduce the bleeding risk? But this increases the chance of stroke, MI or fatal pulmonary embolism, and the guidelines by the ASIPP shows that the thromboembolic complications following interruption of anticoagulation is more frequent and more than the neuraxial hematoma. So this makes our every block in a patient on anticoagulants a calculated risk, and the anesthesiologist is accountable for timing, drug clearance and documentation when performing blocks. So now we do not ask whether should we do a block. What we do is how to do it safely and when to do it. To aid us in this are the American Society of Regional Anesthesia Guidelines and the European Society Guidelines. The American Society Guidelines are taken from the 2025 guidelines and European Society 2022. So what is different in the 2025 guidelines? They have taken into account the pharmacokinetics of the drugs. There is a transition from prophylactic and therapeutic terminology to low dose and high dose. They integrate recommendations for laboratory monitoring. They have also taken into account newer reversal agents wherever applicable. The guidelines also have included, based on renal function, patient-specific thrombosis risk. There is a risk stratification model. So blocks have been categorized into high risk of bleeding blocks and low risk. High risk are the neuraxial and deep peripheral nerve blocks, and these are where the block-induced bleeding is significant and it is difficult to control the bleeding. Low risk, it's the management of bleeding complications is easy. These are the examples of the deep nerve blocks and the superficial nerve blocks as per the classification. Let us now decode the ASRA guidelines. The strengths are 1, 2, and 3. 1 being the highest level of evidence, which is based on randomized controlled trials and meta-analysis. 2 being observation and epidemiological studies. 3 is case reports and expert opinion. Grade A is general agreement, B conflicting evidence, and C is not useful or maybe even harmful. When the guidelines say recommend, it means it's safe to perform, and when it says suggest, that means we have to use our clinical judgment and individualize for every case. So a brief classification of the anticoagulants. So now let us go into details about each of the drugs. So the first drug is apixaban. As we have discussed, it's going to be divided into high dose and low dose. The newer recommendations are based on the apixaban levels and also the anti-10A levels when it is a high dose or a low dose. Edoxaban, there are no recommendations for low dose as it's not FDA approved. High dose, again, the newer recommendations are based on the drug level or the anti-10A levels. Rivaroxaban, the newer recommendations are that there's an acceptable level of less than 30 nanograms per ml of rivaroxaban level or an anti-10A level less than 0.1 international unit per ml. And among the low dose, they have taken into consideration the creat clearance, and the drug has to be stopped at least more than 24. The drug has to be stopped at least more than 24 hours, and if the creat clearance is less than 30 ml per minute, the dose has to be stopped more than 30 hours. So this is the newer recommendations. Dabigatran also, the doses are based on the creat clearance, and they have divided it as creat clearance more than 50, 30 to 49, and less than 30. Based on this, the number of hours the block has to be stopped prior to block varies. These are the newer recommendations. So at present, the recommendations are against the use of antidotes like idarucizumab, andexanet alpha, prothrombin concentrate, and activated prothrombin concentrate to enable the safe performance of a neuraxial intervention. This is again the same thing about the docs. And coming to unfractionated heparin, there are new changes. We have to daily review if there are concurrent anticoagulants which have been added. And if a patient is on ultra-fractionated heparin for more than 4 days, please check a platelet count before the block. A patient on intravenous heparin, the heparin should be stopped 4 to 6 hours before the block. It can be restarted 1 hour after the needle placement. Regarding indwelling catheter with ongoing IV heparin, the recommendations are it should not be continued, and if it's really necessary, we have to monitor it and use diluted local anesthetic concentrations for early detection of complications. Subcutaneous heparin for thromboprophylaxis, the needle placement can be done 4 to 6 hours after the last subcutaneous dose. Very high dose and very high dose of subcutaneous heparin in the preoperative period, it has to be stopped more than 12 hours or 24 hours after the low dose. And there are no changes in these guidelines. In the post-operative period, a low dose of subcutaneous heparin can be continued, and the catheter has to be removed 4 to 6 hours post-dose. If it's a very high dose of subcutaneous heparin in the post-operative period, that is more than 5,000 international units, the safety is not established and individualized risk-benefit ratio has to be considered. Now we discuss about the low molecular weight heparins. Here the general considerations, there are no changes. Its anti-10A monitoring is not routinely recommended, and you do a platelet count if the patient is on low MOS for more than 4 days. The newer recommendation in this, if a patient is on pre-op low MOS, is that if you are planning an early block, that is less than the recommended hours of stopping the drug, or if the patient age is more than 75, or creat clearance less than 30, we have to consider the anti-10A activity level before going ahead with the block. Post-operative low molecular weight heparins are no changes, and this is again based on from the therapeutic to prophylactic dose. They have made it into low dose and high dose. Low dose twice daily, single daily, and single and double twice daily at high doses. The antiplatelet agents, clopidogrel and prasugrel, stop clopidogrel 5 to 7 days before the block and prasugrel 7 to 10 days. Longer intervals may be needed if the patient is at higher bleeding risk. Catheters may be maintained for 1 to 2 days with clopidogrel provided no loading dose is given. we can resume the antiplatelets immediately after the needle removal if no loading dose is considered. If a loading dose is planned, wait for at least 6 hours post-catheter removal. Ticagrelor, the newer recommendation is stop 5 days prior to needle placement. Platelet GP2B, 2 or 3A inhibitors, there are no changes in the recommendations, and silastazole, Cangrelor, and parental thrombin inhibitors, no changes in the guidelines. Coming to fondaparinux, so here they have divided it into healthy patients with normal renal function, healthy elderly patients with normal renal function, healthy patients it's hold for 36 hours, and healthy elderly patients with normal renal function 42 hours. Create clearance less than 30, you avoid neuraxial or deep blocks, and if you want an early needle placement, do an anti-10A activity level. So when a patient is on high dose, so young patient with normal renal function, hold it for more than 70 hours, elderly patient with normal renal function more than 105 hours, and check for the anti-10A levels. Thrombolytic therapy, check history for recent neuraxial procedures before the planned thrombolytic therapy. Frequent neurological monitoring every 2 hours for at least 48 hours after the last thrombolytic therapy. There are no changes here. The only thing is to be noted is fibrinogen is the last clotting factor to recover. Now, vitamin K antagonist, warfarin, the anticoagulant should be stopped 5 days prior to procedure, and INR should be normalized. For low dose, INR should be monitored daily. Neuraxial catheter should be removed when INR is less than 1.5. If it's more than 1.5 or less than 3, catheters may be maintained or removed with caution. If more than 3, hold or reduce the warfarin dose with indwelling neuraxial catheters. Slides are not moving. 1 second. The slides are not moving. There's a technical glitch.
Internet is disconnected.
Okay. Yeah, I'm back. Sorry for the delay because of the technical glitches. So regarding NSAIDs and herbal medicines, there's no change. Use of herbal medicines does not pose significant risk for neuraxial blocks, and there's no requirement of mandatory discontinuation. So we have spoken about all the drugs at theory part. Let us now see a few clinical questions and clinical scenarios. So is there a difference in time interval between combinations of antithrombotic drugs? So if my patient is on a combination of many drugs, I will use the therapy-free interval of the drug with the longest interval. So this is the recommendation. Is there a difference in time interval between patients with or without bleeding risk score assessment? Yes, bleeding risk score assessments have no influence on the time interval from the last intake to the intervention. Is there a difference in time intervals between patients with or without drug measurements? There are no randomized control trials as of now which have measured the drug levels prior and after the block and the incidence of hematoma. So what are the recommended monitoring? If a patient is on ultrafractionated heparin, APTT, anti-10A or ACT, LOMO, anti-10A, and direct 10A inhibitors, the drug level or the anti-10A. There are no routine lab tests for aspirin or P2Y12 inhibitors. So is there a difference in time interval if patients are on with or without reversal of vitamin K antagonists or DOX? So if a patient is on vitamin K antagonist and an urgent block has to be performed, it can be fully reversed by prothrombin complex concentrate. It should be INR dependent and dose adjusted, and always combine it with vitamin K. Dabigatran is fully reversed by idarucizumab, and prothrombin concentrate does not affect the time intervals. Andexanet alpha also does not affect the time interval. If my patient is on low molecular weight heparin or fondaparin X, and I need to do a block urgently, so what do I do? So patient on heparin, we should fully reverse it with protamine, but always look that protamine overdose should not be there. Fondaparin X and low molecular weight heparin, there are no recommendations for reversal. A patient on aspirin or P2Y12 inhibitors, what do I do? Low dose aspirin, if a patient is only on low dose aspirin, deep nerve blocks are not contraindicated. When loading doses of antiplatelet drugs are given, deep nerve blocks should not be performed, and there is no recommendation for inhibitor reversal. If I use an ultrasound, is there a time difference between withholding the drug? So ultrasound definitely reduces the vascular puncture, and it is recommended in patients on anticoagulants, but there is no influence on time interval from the last administration. There is no evidence that ultrasound reduces the incidence of hematoma. Is there a difference in time interval between needle and catheter insertion versus catheter removal? Yes, similar time should be respected for insertion of the needle and the removal of the catheter. Is there a difference in time intervals between deep and superficial nerve blocks? Yes, superficial nerve blocks can be performed in the presence of anticoagulants or antiplatelet drugs. Deep nerve blocks should be performed according to the recommendation. The consequences of low bleeding caused by block should be considered. Always consider a block with the lowest bleeding risk technique. Is there a time interval difference between patients with or without blood? If I see blood in the epidural needle or in the catheter, should I go ahead with the block or what should I do? So the European guidelines say that a bloody tap may warrant delaying the next antithrombotic dose, but this would be a multidisciplinary decision taking into consideration the thrombotic risk, the perioperative coagulopathy, post-op hemostasis, and antithrombotic pharmacology. The ASRA also does not recommend mandatory cancellation of the case. So if there's a spinal or how to look for a spinal or epidural hematoma after a neuraxial block. So the recommendations are there should be a multidisciplinary healthcare team, look for signs and symptoms related to any new or progressive neurological deficit, any new onset of pain, numbness, weakness of legs, bowel, bladder dysfunctions. So now we have gone through the guidelines. We've also seen each drug what to do. So how do we manage this tightrope? So regarding decision making, always remember, assess the patient, look for the comorbidities, assess the pre-op investigations, and review the patient in the clinical context. Determine which is the anticoagulant, when, what is the type, and when it was given. Optimize documentation and communication. So documentation is the keystone, and communicate with the team. Monitor this patient, follow-up is very essential. How to avoid complications in patients who are already on anticoagulants and the regional anesthesia is planned. Always monitor for a neuraxial hematoma. There could be unrecognized renal impairment, so look for it. Optimize premature restart of the anticoagulant, and communication across teams. So documentation, what all do we need to document? The timing of the last anticoagulant dose, the latest INR, the renal function, the risk-benefit discussion. Consent must state risk of bleeding and neurological injury in an anticoagulated state has been discussed. The anesthesia record must include anticoagulant management as per ASTRA 2025 guidelines. So what are the future perspectives in this? So probably we would have point of care coagulation testing in the future, AI-based decision support where algorithms would help us decide how to do, when to do. And there are newer drugs, of course the anticoagulants, and there are newer reversal agents also. So probably the newer guidelines should consider all these also. So the final thoughts, know the drug, know the block, know the risk. The timing and reversibility matter. Documentation is your best defense. All when in doubt, consult. So not every needle is the same. Not every drug bleeds the same. Your decision shapes the outcome. Walk the tightrope with knowledge and caution. Thank you.
was an informative and precise presentation, Dr. Lavanya. And the session is